We have reached the final segment of the conference, and we are very grateful for your continued engagement. We just finished a very comprehensive segment about international partnerships. Before that, we had a very comprehensive segment on practitioners' perspectives from many parts of the world. Yesterday, we went through also very comprehensive segments trying to complete a program about type 1 diabetes and an aspiration to advance a global roadmap for improved and integrated care in low-resource settings. We are now at the final segment of the conference, and the final panel will start now, and after that panel we will close the conference with the closing segment. I also remind everybody to approach the colleagues at the conference desk when we conclude, after conclusion, if you have any final questions about airport transport and other logistics. But we will start the final panel, which is entitled Reflections, Persons with Lived Experience. And the co-moderators of the panel are Mark Barone, who has already been speaking, but will be now moderating, representing the Intersectoral NCD Forum Brazil, but also is a person with lived experience of type 1 diabetes, as you have said. The other moderator is Renza Scibilia from Breakthrough Type 1D, but is also a person with lived experience from type 1 diabetes. Please. And in the panel, we have Christine Nabatansi from the Sonia Nabeta Foundation and from Uganda. You met Christine yesterday, a person with lived experience of type 1 diabetes. Zoran Stojkovski from the Union of Associations of Persons with Diabetes of North Macedonia, a person with type 1 diabetes lived experience. We have Ileana Gil from Venezuela, Guerreros Azules, Blue Warriors, who is the mother of two daughters with type 1 diabetes. And last but not least, Newton Ngugi. Where are you, Newton? Yes. From Kenya, who is actually my colleague in World Diabetes Foundation, but he's also an advocate of type 1 diabetes and himself a person with lived experience of type 1 diabetes. And with that, I'll hand over to the two co-moderators, Renza and Mark. Please, a panel of reflections about the conference from the perspectives of you, moderators and panelists. Thank you very much.
Am I starting? Oh, hi everybody, I'm Renza Scibilia. We've got lots to say, and we are going to have a session with reflections. But I think we're going to start with Christine, and we're going to ask Christine to go up there because she's more comfortable speaking there. So we'd love for you to kick this off with your comments and what you would like to say, which is a bit of an introduction and setting the scene, but then from there we will really focus on reflections. This is a very interactive session. You've made it to the end, and we're so thrilled that you are here, but we would like to ask for your questions as well. So please do start to think about what you would like to say. Mark, did you want to just say something as an introduction, or will we let Christine? No? Okay, Christine.
Thank you. Good afternoon, ladies and gentlemen. My name is Christina Batanzi, a warrior coordinator, Type 1 Diabetes Clinic, Ginger General Faro Hospital. Ginger General Faro Hospital with Sonia Nabeta Foundation. I'm here to talk about the last mile. What is last mile? Last mile means the remote location where access to transportation, electricity, and basic infrastructure is virtually non-existent. Me, myself, I am a child from the last mile, born into abject poverty in Mochigudu village, Buyukwe district, the third of 5 children with mother and father, peasant farmers. Diagnosed with type 1 diabetes at 18 years old. I was working as a maid and I lost my job. I was returned home where I was isolated. I was seen of no use because they thought I'm dying soon. A local NGO started supporting me because I was doing well in school, and I was able to get my teaching certificate. After my teaching certificate, I have been able to continue with my education through SNF's scholarship program for my diploma in special needs education. I am now a warrior coordinator at Ginger Clinic Hospital. With over 130 warriors under our care, I work with our clinic nurse to conduct home visits, follow up on warriors, clinic attendance, attend crisis intervention. Now a warrior educator in training, hoping to get certified as a diabetic educator in July 2024. From child to a warrior educator leader. Survival is our primary focus at the last mile. Our problems are access to healthcare facility, poverty and food security, awareness, stigma and psychosocial stressors, literacy, and type 1 diabetes. For example, I have 3 siblings in our clinic. One a girl and 2 are boys. They come from Nawasonso village in Kamuli district, Uganda. A girl is 8 and 2 of her brother. One is 10 and 12 years old. Mother abandoned them because of their condition. Father is a border rider. Grandmother is aging and unemployed, is their primary caretaker. Father brings home less than $2 per day. On average, 3 nights a week, there is no food at home. The home does not have electricity or a refrigerator to store for the insulin. Another example. Another warrior comes from Buzama village, Buyukwe district. This is my village. 5 years old, was diagnosed with type 1 diabetes at 3 years old. Father deceased and mother is a peasant farmer. Travels 3 hours to the nearest health facility. Our clinic serves over 130 warriors. This warrior has to be served. The nearest pediatric endocrinologist is in Kampala, 1 kilometer away. Our data at SNF has shown 72% of warriors, they feel are financial burdens to their families and caregivers. 68% are afraid of their friends and community finding out they have type 1 diabetes because they think type 1 diabetes, it is contagious. 33% are afraid of being excluded from activities at home because of their condition. And 34% are afraid of being excluded from school or thrown out because of their conditions. Also, in Uganda, SNF camp data has shown that in eastern Uganda, 81% have difficult understanding glucometer reading. Similarly, 77% need help from caregivers to understand and manage type 1 diabetes. Numeracy, literacy, and cognitive skill are a must for a good outcome. Type 1 education and community are essential. So, the future I would like to see, number 1, access to insulin, syringe, and essential supplies. To us warrior, insulin is life. Sustainability of essential supplies is a big source of stress of a warrior and their caregivers, so continuity of supplies, supplemented delivery mechanism is essential. The government and the broader NGO communities are important to make this possible. Number 2, improved health infrastructure. Health workers are not knowledgeable as they could about type 1 diabetes. There is need to train them so that they can transfer correct information to the warriors. Education is the big part of type 1 diabetes management. Programs like SNF, a word of warrior, can be scaled up to improve access issues. Number 3, let's also focus on social determinants of health. Poverty is endemic and exacerbates challenges with type 1 diabetes. How can you inject without food? How can you find transport to clinic? Stress. Optimal type 1 diabetes requires carb counting and adjusting insulin. But how can you count when you cannot read or write? Stigma communities causes stress to the warrior. School discrimination also causes stress to our warriors. The future of a warrior, the future is a world of warrior by warriors. Without type 1 community, I would be nothing. Type 1 diabetes is hard and harder in developing world. Building a thriving community with warriors with lived experience, the heart of type 1 diabetes care model. At SNF, our ultimate goal is a world of warrior by warriors. Thank you so much.
Thank you very much, Kristen. Wonderful to share. So all your experience and everything you have been doing in your community, really changing reality of so many there. It's very inspiring to us all. So I'm going to invite now for also a statement for introductions, Zoran Stojkovic, please.
Actually, I think we might, because we don't have long, let's actually just stay sitting here if that's okay. Thank you.
Thank you. I was 26 years old, young adult, when I was discovered with type 1 diabetes. And from these 27 years of my life living with type 1 diabetes, I can summarize my experience during this period like constant struggle of being responsible. First of all, being responsible for my family. I have 3 daughters and 1 son. Constant focus of income, actually work, and being responsible towards myself. I must say that as a people with type 1 diabetes, these last responsibilities often I forget. And meaning that being thrown apart between my private and my professional life, working hard, and I feel a lot in being in stress, and then as a result of it, my blood sugar is quite often quite high. What I have learned here during these 3 days, I must say, and this is one of the questions, and what I'm taking back to Macedonia. I must say that I'm also sending my best regards to everybody, not only in this as a participants, but those that are following online, because I know that there is, especially I know that in Macedonia there are people that are following. I spread the word, but something that I want to stress that for me the most important things that I bring, that actually I have opportunities to talk with you, to reflect on things related to conditions of people with type 1 diabetes. Often in this system that is actually created between health institutions, government, NGOs, civil society organizations, academia, probably international organizations that are active, usually people or individuals with type 1 diabetes are being forgotten, because it's absolutely for me, it's the most important that person, any individual with type 1 diabetes, to have care, but that means not only access to insulin, not only access to CGM sensors. Sometimes, these types of discussion or learning between each other. Myself, I'm really pleased that I have community back in Macedonia that I can talk with about my health condition. Unfortunately, as a country in development or not so developed country, I must say that I learned also that we are happy in Macedonia that we have free of charge insulin for type 1 diabetes and people with type 2 diabetes, which is absolutely something that I heard that others don't have, or they have until 18 years old and then they have. I really, I'm pleased that from first day on insulin, insulin is free of charge for us. We have, I was talking first day that unfortunately the way of tendering every second years we are getting these devices for measuring glycemia, no name, low quality, but at least we are getting. But that doesn't mean that we have to be happy. Hey, now we have insulin. We have glucometers. No. Probably in every context, especially in those with lower resources, we have to fight for our rights, every single person. And from that standpoint, I think that I would really appreciate if, especially donor community, but also international organizations, consider improving capacities of civil society organizations, of patients organizations to actively advocate and lobby.
Zoran, we'll leave it there, but thank you so much. We've got more questions, so we'll come back to you. But
good point.
Yes.
Yeah.
Ileana, if you could introduce yourself and reflections from this week. Obviously, we've got lots of questions. We want to have a discussion.
Good afternoon, everyone. My name is Ileana Gil. I'm the co-founder of Guerreros Azules, a non-for-profit organization that empowers kids with type 1 diabetes in Venezuela. I'm a mama pancreas, a blue mama, a mama of a warrior, like we call it. I'm here representing all the caretakers and the parents of kids with type 1 diabetes. Our organization main core is education of the caretakers and the parents, because if you have educated parents, they can transmit the message to the kids, and then once the kid is old enough, then the knowledge is there and the management is there. Managing diabetes, as we all know, is a 24/7 homework, to put it, work all the time. And it requires also, like Christine says, mathematics, memory, writing, memorizing carbs. If you have access to apps, you have the apps. In some countries, we don't have access to that. Then you need to have a big book carrying around the carbs. Then you also need to carry around your devices, whatever you use, to school, from school. And in some places, parents need to go to school with the kid, or otherwise they don't get access. There's a lot of factors that go into play. And our core is to empower all those families. We use a lot of media to create awareness. We've done several post documentaries. We do talk radio shows, small TV shows. We go to schools, and we do a lot of recreational activities as well for the kids to come in and meet each other and know that they're not alone, and especially that the parents also know that they're not alone and that they can rely on each other.
We'll ask for your reflections in a moment.
Oh, yeah. Sorry, I didn't say the most important thing.
Go.
I'm a proud mama of 4 girls, 2 who have type 1 diabetes. My third was diagnosed when she was 4 years old, 8 years ago, and my oldest was just diagnosed last year. She's now 17. Sorry, I should have said that from the beginning.
That's okay. And we'll come back to you and ask what your big takeaways from the last couple of days have been. Okay. You're up, Newton.
Thank you, Renza. And my name is Newton Gugi from World Diabetes Foundation. Program manager, and I also wear a couple of hats. I also do podcasting and also into advocacy as well. I think, I know we are short of time, but if it's just my request, I know there are so many people living with type 1 diabetes who would have been here, but they are not here, they departed. So if we could take 30 seconds of silence just for that. Thank you. Thank you for that. So for my reflections, maybe I'll just start with one, and this is when I look at type 1 diabetes in a low resource settings, what's the first thing that comes to your mind? In contrast to high income settings, the reaction that I have is look at the role models or the people who have made it with type 1 diabetes in high income countries. Let me draw a picture for you. There's a player who plays for Real Madrid, and his name is Nacho Fernandez, and he has won 5 Champions League titles, being a type 1 diabetic. For those who watch football, it's difficult to win 1 Champions League title. He has won 5. That's in Spain. We go to the UK. The former Prime Minister of UK, Theresa May, also has and living with type 1 diabetes. Those are 2 high-income countries. When you put a contrast to the lower income countries, there is no role models. There is no local champions. So even if you are diagnosed with diabetes in a high income countries and your former prime minister was living with the condition, automatically you become elevated even in your psychology. That's the first thing that we have to notice. And that can play around in your absence of good healthcare systems, good data, and all that. But that really plays around. Gathering the presentation from Tanzania, I was looking at what they are considering as their life expectancy. The life expectancy in Tanzania is 66, in Kenya it's around 62. But when you live with type 1 diabetes, are you able to achieve that life expectancy? That's the first metric that I look at myself. If I will ever be able to achieve and supersede or surpass that life expectancy, that for me is success. But it will not be success if I do it alone. I want it to be the success that will be taken normally for the rest of the type 1 diabetes community. And I think for me, that's a very, very key ingredient or what I've captured from the last 2 days. The other bit is on actually the quality of life. So the quality of life, how does it come into being? As a child living with type 1 diabetes, who are your go-to persons, especially as Mama Blue has put across? Parents living with these children, do they have like a sort of a support system whereby they can be able to share experiences? This proposal I'm putting across, they will happen in the absence or in the presence of resources. And for me, I want just to put a thing on community engagement and support, whereby we can come together as people living with type 1 diabetes, our parents, the guardians, and share how we can be able to even create a program that can improve even our outcomes in that regard. So I think for me, those are the two things that actually stood out. And those are the things that have actually made me understand and actually made me appreciate this conference. This is the first conference for type 1 diabetes. I've been living with the condition for the last 12 years. I've not had any elsewhere. And I also want to take this opportunity to say thank you to WDF and the collaborating partners and make it a habit as we go on, so that at least whatever we put on paper, we can be able to ensure that we go on with it. And maybe lastly, before I also forget, is what is it that we can do next week to improve a person who is living with type 1 diabetes and ensure that we leave no one behind? If you look at the healthcare system, is it possible, because we have support groups, when we are prescribing medication, we also prescribe support groups. I'm sure you do not need funding for that.
Thank you very much. Thanks for the very meaningful reflections here to start our interaction. I don't know if we should open for some questions, or if we discuss a little more while you prepare some good questions for our panelists here. Okay. Oh, there are two questions already there.
Okay. So I had a question. I thank you all very much for speaking in this panel. I had a question. I mean, since, you know, there's been a lot of questions about, like, if you had a magic wand, what would you fix or whatever. But I think for me, something that would be really interesting maybe for governments and donors to hear is, from your experiences, from your in-country experiences, from your experiences with your diabetes group, what is the one, like, most effective thing that you have found from the perspective of people living with diabetes or your diabetes groups that you wish that governments, doctors would know and take forward into something that's a more systematic program?
I think if you could answer in one sentence, each one of you one sentence, and then we go to the next question, would be nice. Yeah, you, please.
Something that is also take from here, from this conference, that really I would like to see in several years, diabetes advocacy watch on national level by different countries. Because I think that we must have tool as, let's say, union of association of people with diabetes in Macedonia, but also probably on, in every countries in development. We have to have tool to press government if they are not responsible, if they are corrupted in choosing the equipment or insulin. And I think that this is my biggest wish, and okay, maybe will not happen
advocacy
in Macedonia,
in all countries. Thank you.
Hopefully in a few years.
Lena?
Well, simple. From the point of view of our caretaker, education, like I mentioned. Education for me is the most important thing. Education along support, a support group that comes hand in hand, are what will be my number one.
For me, in addition to Macedonia and also from Venezuela, I think also creating awareness. I know the aspect of, and I'm glad you started on the data aspect, because absence of evidence is not evidence of absence. So I think we create awareness countrywide and globally and regionally to ensure that everyone knows type 1 diabetes exists, even if it's 5 people in a country of 1 million? Thank you.
Thank you for the question. Me try not to be different from my fellows. Awareness. For us in Uganda, they don't know type 1 diabetes. The government is more concentrated on type 2. So we need awareness. Another thing, we need insulin to be accessible. So without Sonia Nabeta Foundation, we are gone. We need insulin to be accessible, also to be for free or cost free for. I think you've understood it. Yeah. And
Wonderful.
also another thing, we don't have, like, our clinic are very small. They are not enough. So if it is possible to enlarge for the what, to be enough for us. Thank you.
Wonderful. Renza, I think you could also bring your...
Everything that everybody has said, I just want to say yes to all of it. The two things that I would perhaps, I guess, really reinforce is peer support. I think that we too often think that peer support is a bit of a tea and sympathy. It's a nice to have. We sit around, it's all really lovely, and we have a cup of tea and that's it. Peer support saves lives. It really does. And I don't know if it's because we say peer support groups or I don't know if it's a terminology thing, but I don't think that people understand the impact of people with diabetes coming together to learn, to laugh, to live, to cry, to celebrate, to commiserate, all of those things. There is such power in that. But it goes beyond just what we can do for each other. It's how we can also support you. And there are so many examples that we have heard and seen in this room already and beyond that we can hold on to. So if you're coming from somewhere where this hasn't been something that you've thought of, you don't need to start from zero. I think that's a really encouraging thing. You don't need to start from zero. There are so many learnings already. What about you?
Yeah, if I could contribute also with this discussion, obviously I would agree with all that has been said so far. And I would add, so meaningful engagement in all decision aspects, in all decision opportunities, so that will affect people living with diabetes, the participation, the meaningful engagement of people living with type 1 diabetes. I usually say, so sometimes it's with the best intention of, from administrators of health system, from clinicians, etc. But when it's not with the participation, maybe it, even with the best intentions, it will be a waste of resources because you may not know what is the real need and if that will work or not if you don't hear from the ones with the condition. If we could go to the next question.
Yes, hello, my name is Omar Silverman. Thank you for sharing. It has been touching listening to you guys. Because you are echoing a voice of different people, I just want to know, how do you make sure that the message that your community or the other persons are giving to you, how do you make sure that you are transmitting their message or their message and not only your message? Thank you.
Actually, really key question for us as patient organizations. Actually, the sad reality is that we represent quite low percentage of people with type 1 diabetes, or even all community of. Nowadays, it's more and more harder of people to believe in something because, they're just not believing in whatever we do as activists. The example from last year, November, we started petition against urging government to get funds for CGMs. Only 1,500 signatures of online petition. Out of 140, even more people with diabetes, and these links must exist if we want to talk about influential movement of people with diabetes. this is one of the reasons why governments just are not taking us seriously, because we cannot mobilize more support. Unfortunately, that's true in my country.
Well, in my organization, we're over 900 kids and 300 families that were on constant communication. And I think I've established myself and my other 3 moms who are co-founders, a very close relationship. It's been already 8 years since we started the organization. And for every new family that comes in, it's part of our big family, from the Guerreros Azules family. We consider all each other, all blue mamas, all blue kids, all blue daddies. I think what I'm asking here, or what I'm trying to portray, represents all what they also feel in terms of the community of the parents of kids with type 1 diabetes.
I think we could get another question then, if you want also to comment that one. So I'm not sure who's then the next. Okay. Yeah.
I think, or I'd like to think at least, that every single person in this audience believes in the power of peer support.
Please introduce yourself when you have a question.
Oh, apologies. It's Emma Clayton, Life for a Child. So I'd like to think everyone in this audience believes in the power of peer support. But, you know, Newton, you said that peer support doesn't necessarily need investment, but I think it certainly requires a disruption in the power dynamic locally. And so I wonder if any of you could share any resistance that you've come up against in trying to implement peer support programs.
Thank you, Emma, for that. And I say that with much bravery, because the health system, the way it's designed, there's a reason why we are called patients. I hope that has got home. There's a reason why we are called patients. So when you try to change the dynamics of that language, and I'm glad Renza is here, because language matters, because as a person who lives with type 1 diabetes, unless I have an issue that has taken me to the hospital, I'm managing the condition back at home. So you will tell the facility or the healthcare provider that I only come to the facility to either pick my medication or to also check up on the rest of the people who are also living with the condition. So the power dynamics has to come from a point of letting the healthcare provider understand that you are saving them time, workload, by you being actually in better shape. So I think for me it's just changing the tune and giving them the value, because humans are people who they go where there is benefits. So if you go in a facility and they have like 500 patients and 150 are people living with type 1 diabetes, if they are well controlled, it will actually make the work easier for the healthcare provider. That will also cut into the cost that will be saved by the government and the health system, in that not many people will go to complications. So I think for me, it's them understanding and you being able to share that you are doing this to save your life, to save the country cost, to save the productivity of the country in terms of human resource ability to work and all that. But the dynamics has to come from you understanding your value as a person with lived experience. Well, the name patient will remain, but at the end of the day, I am managing this condition and coming to your facility for less than 20 minutes in a whole year. Thank you.
I think we have another question. Yes.
Thank you. Mine is not a question, it's just a comment to my fellow clinicians. In most cases, we think that we are the one who are knowledgeable. Oh, my name is Omar Buguyu. I'm an assistant director and head of NCD Mental Health and Injuries from the Ministry of Health, Tanzania, and I'm a psychiatrist by profession. So mine is just a reminder to my fellow clinicians. In most cases, we think that we know and we prescribe to patients, but for the past 2 days, when we hear Christine gives testimonial, you'll understand that we know a little about the condition. We know pathophysiology of the disease, but the needs of the patient we don't know. So let us reflect and take time to ask our patients what are they going through, and could probably serve them better rather than looking for HbA1c, checking for the complications. Sometimes this medication doesn't work if the patient is suffering from other social and psychological issues. So just a reminder to my colleagues.
While the microphone is finding its way to the next question, and perhaps I could just make a return comment to that. We've already mentioned language, thank you. And I think that part of it is a bit of a shift in language there. We very rightly and easily refer to our clinicians as experts, and we refer to our researchers as experts and to our policymakers as experts as well. But people with lived experience are experts as well. No one else can do what we do. No one else can tell the story that we can. Our expertise is on par with the other areas of expertise. So that's something to think about as well when you're putting together advisory groups, when you're putting together steering committees, that you hurriedly put together with your clinical experts, with your research experts. Where are the lived experience experts? They should be equally weighted and have the ability to influence as well. It shouldn't be a tokenistic, we'll do it at the end, oops, we forgot, let's quickly do it now. So that's just to, I guess, reflect back on what you've just said then.
Yeah, sorry, this is for me quite part of my story. How I learn who is good, who is not good as an endocrinologist. We have really lack of, as a total of people with dealing with diabetes, including also specialists like ophthalmologists, nephrologists related to diabetes. And in our country, you must, as a type 1 people with person with diabetes, to go to check with your endocrinologist. And then even you don't have your own doctor because it's system, and then when who find in the system who is available, you will go with him. And then there was always one person available. Everybody were busy because of schedule. And then I went to the guy, and he said, "No, this is not good for you. I will change you insulin because I have some higher levels of sugar." And then my condition went worse and worse. And then I went to another doctor, and a younger doctor, and she said, "But who gives you this insulin? This is insulin for type 2. I'm type 1 from very first day. But because I am obese, and then he thought, he's type 2. And then because of that, my condition get worse. And now I know. And I also recommend to everybody not to go to this doctor. Unfortunately, that's my sad story. But as I said, retinopathy, nephropathy, it's kind of, and especially I cannot return time back.
Well, on that cautionary tale, we will now ask, yes, another question.
Professor Bishwajit from Diabetic Association Bangladesh. So my question to all of you, could you please share at least one thing about yourselves that you learned through this journey that makes you proud?
That's a good question. Thank you. From Bangladesh. I think for me, yes, I was diagnosed 12 years ago, and I was in denial for around 3 years. And I was in campus and everything else. And I started this advocacy journey with around 4 other guys. And I've lost 2 of them on the way, so we've remained 3 of us. I think for me, every time I wake up in the morning, my question is, have I done a lasting impact in the type 1 diabetes world? I ask myself, that question keeps me up 2 a.m. in the morning, not because I have nothing else to do, but because at the end of the day, it's about life. And I don't want to see another person who I know lose life, and maybe there's a way that I could have done. Coming in fruition in that is that I sat down and asked myself, what can I do more? Because the community was approaching me and telling me, we don't have education. We want to learn more. When we go to hospitals, we are kept with people who are living with diabetes, but not to sound like I'm bragging, but they are over 40 or over 50. What education will you give people who are over 40 and 3 of us are below 20 or below 30? So I sat down and told myself, can we do like podcasting, like something that is similar or something that is easier to digest as a person who is 20 or 25 years old. In that way, we are able to reach out to the masses and people come together and say like, I've improved simply by watching things or simply by listening to you sharing your experience. And at the end of the day, I want also to believe that with programs like with WDF, and that's where I've also found myself in, and I take that in pride, because all the programs that we undertake at WDF, we have diabetes associations from respective countries. That is massive. I'm coming from Africa and I've seen programs come and fly by, but they do not involve the people living with the condition. The moment they left, that vehicle does not move from that station. It stops there. It has everything, it has gas, it has everything. But the involvement of the people living with the condition is truly massive for me. And I also want to use this opportunity to show people that it can be done. You can live with type 1 diabetes from Africa, go to Europe, go to wherever you are going. You can even do your thing like Elon Musk and everything, because this is what is happening in other countries. And we are all having the same condition. Because what happens is that we experience a lot of medical tourism. In Africa, you find that in other countries you have better systems of healthcare. People will move to those countries and then leave our state the way it is. So for me, if I'm able to answer that question every day and I get a positive answer, that's enough gas for me. Thank you.
Christine, did you want to answer that? You just need to press the button. Yeah.
For me, what made me happy, my experience, before meeting Sonia and Abeta Foundation, my life was miserable because access to insulin was a problem. Even seeing the medical personnel was a problem. So when I met Sonia and Abeta Foundation, my journey changed, and also I was sponsored with my education because of the support I received.
We have more questions. So yes, Tino, introduce yourself first, please.
Okay, Tino here from Zimbabwe. Okay, so my question is maybe directed to Renza. So because this is something that I believe it gets under your skin when you hear something like this, as someone who is an active person in diabetes and language matters. So there's something like some words that we usually hear from our doctors, and I've heard other colleagues of mine complaining to say, I don't want to go back to the clinic because of the way the doctors speak, like the words adherence, non-adherence, you're not doing everything the way, I don't know, those kind of words that talk of judgment. So maybe if you may employ, or maybe just share with some of the doctors here, if there's a manual of the things that they should say and supportive. I don't know if there's a international consensus statement, or maybe that you can share with them. That would be good.
This session's meant to finish in 2 minutes, but strap in because we're here until next week. No, we can keep going. So there is a movement called the Diabetes Language Matters movement, and I would encourage everybody to get online and have a look, because actually, yes, there is a manual. There are dozens of them. There are position statements that have been written by people with diabetes, working together with clinicians and researchers from, I think we're up to about 18 or 19 countries now around the world in a number of different languages, and we're always very keen to add to that as well. But I think the basis of what the Language Matters movement is about, it's not about individual words. It's not about getting hung up on whether somebody is a diabetic or a person with diabetes, because it's a very personal decision how people would like to be referred to. It's about treating people with diabetes with respect and communicating in a way that makes us not feel beaten and feel put down, that makes us feel empowered and makes us feel supported and makes us want to come back to clinic. And Newton said something yesterday. He said that we remember the words that were said to us by our clinician when we were first diagnosed. I was diagnosed 27 years ago, and I can still remember the words that my endocrinologist said to me on that first appointment and how harmful they were. And it wasn't because he was a bad person. He was really nice. But he was saying words that were very judgmental and very stigmatising, and that made me feel that if anything went wrong, I failed and it was my fault. But surprisingly, that if everything went well, it was because of him. I don't know how that works, but that was the message that we got there. Go and have a look at the Language Matters documents and learn about them and speak with the people that you see. It isn't about individual words, but please, please don't ever refer to somebody with diabetes as non-compliant, ever. And really never refer to somebody with diabetes as non-compliant if they are living in a setting where access to insulin is almost impossible, where access to healthcare is impossible. How can you possibly be compliant if you can't access what you need? And don't say it to people in high-income settings either. Diabetes is a really hard gig. It really is very difficult. I have an incredible endocrinologist who says, "Thank you for coming when I go to my appointment. Thank you for showing up." I think that's pretty amazing. We show up. It's an act of faith for us to be there. So hopefully that sort of gives you a start of that, but I could speak forever. I won't. Have we got time for 2 more questions? One more. One last question. Make it good.
Phoebe from Kenya. It's not a question, it's a comment. I think I've been challenged as a clinician that when I go back home, I have to ensure that I'm confident enough that if a patient comes to my clinic and meets the multidisciplinary team, that patient is living with the same information and same instructions across the board. That they should not get different information from the doctor, the nurse, the psychologist, because it all causes confusion. Thank you.
Well, thank you very much. We'd like to stay here with this discussion for some more hours, but unfortunately we would need to finish. But it was wonderful. I would say, just to close, that so this meeting wouldn't be the same, wouldn't be that meaningful if not so engaging people living with type 1 diabetes as it was and it is till the very end. Thank you very much.
Thank you.